Greater omentum and lesser omentum are complex peritoneal folds. They pass from the stomach to the liver and also the biliary apparatus. They pass from the stomach to the transverse colon, stomach to the spleen, and even stomach to the diaphragm. The pancreas is posterior to the stomach. There is also a fold of peritoneum which passes from stomach to the pancreas. We can clearly see that this is the stomach right over here. Is the liver which is reflected, and there are folds of peritoneum which are traveling from the stomach to the liver and the biliary apparatus, stomach to the transverse colon which is here, and there's another fold of peritoneum which is stomach, from stomach to the spleen. This folds of peritoneum actually develops from something called as the dorsal and the ventral mesentery. If you look at this diagram right over here, this is a straight alimentary tube which is formed in the embryo, and this alimentary tube is suspended from the posterior abdominal wall with the help of dorsal mesentery, and it is suspended from the anterior abdominal wall with the help of ventral mesentery. So the dorsal mesentery and the ventral mesentery eventually give rise to the greater omentum and the lesser omentum. So the alimentary tube is initially a straight tube which is suspended posteriorly by the dorsal mesentery and anteriorly by the ventral mesentery. Coming to the embryonic stomach. The embryonic stomach is initially a straight tube, but after some time it rotates by 90 degrees. When it rotates by 90 degrees, what happens is the lesser curvature actually comes towards the right and the greater curvature comes towards the left. Much of the ventral mesentery eventually gets reabsorbed. It is the dorsal mesentery which usually persists and it grows. So if in this diagram we can see that this is the alimentary tube, and posteriorly there is dorsal mesentery, and anteriorly there is ventral mesentery. This ventral mesentery is very short because it eventually gets reabsorbed, and when stomach rotates by 90 degrees like this, so the lesser curvature of stomach eventually faces the right side, and the spleen and the connection fold of peritoneum is present over here. Spleen comes towards the left and finally lies on the left of the stomach. So much of the ventral mesentery is reabsorbed. However, a part of the ventral mesentery persists, which extends from the porta hepatis to the duodenum and the lesser curvature of stomach, and this part of the ventral mesentery which persists is actually called as the lesser omentum. Now let us look at the lesser omentum. This particular structure is the lesser omentum. The right border of the lesser omentum is actually a free edge, which means it is not connected to anything. So this is the right border of the lesser omentum and it is a free edge. It forms the anterior border of opening into the lesser sac, which means if you put a finger, if you follow the arrow and put a finger through this free edge inside, this forms the lesser sac. Alright, this forms the lesser sac. If we put a finger through this free edge of the lesser omentum, we enter the lesser sac which is posterior to the stomach. So the right border of the lesser omentum is a free edge. It forms the anterior border of the opening into the lesser sac. and this opening has a name, and this opening is called foramen of Winslow. If you take a look at the diagram over here, this is the lesser omentum. The right border of the lesser omentum, which is actually a free edge. In this right border, there are three structures, that is the common hepatic duct, the portal vein, and the hepatic artery. From the greater curvature of stomach, there is a sheet of peritoneum which arises, and a part of the sheet attaches to the transverse colon and it becomes a transverse mesocolon, and a reflection of the sheet comes downwards up into the pelvis across the small intestine, and that is called as the greater omentum. Now let us look at the normal rotation of intestine in brief. The small intestine initially elongates and herniates out. We all know that. So after elongation and herniation of the intestinal loop, the intestine first rotates 90-degree anti-clockwise on the superior mesenteric artery axis. Alright, on the superior mesenteric artery axis. So this is followed by the intestine rotating further 180-degree anti-clockwise. So the intestine after herniating rotates a net amount of 270 degrees anti-clockwise. This brings the cecum to the right and the ileum to the left. So the cecum initially lies on the left side, but after 180 degrees of anti-clockwise rotation, the cecum eventually gets placed on the right side of the abdomen. So the cecum has to come down here. For that, the cecum has to grow, and the cecum comes from the upper abdomen to the right lower abdomen after growing. Next, we come to the concept of root of mesentery. One concept is very clear, that is the ventral mesentery will disappear and the dorsal mesentery will persist. The dorsal mesentery basically contains the blood supply to the small intestine. The attachment of the dorsal of mesentery eventually becomes the root of mesentery. The root of the mesentery extends from duodenojejunal junction over here to the right iliac fossa. The lower end of the root of mesentery comes to lie anterior to the right iliac fossa. If you look at omentum and mesentery, they are very richly supplied with lymphatics and blood vessels. Omentum contains areas of high concentration of macrophages, actually called as milky spots, which aids in the removal of foreign material and bacteria. Whenever a structure inside the abdomen or inside the peritoneum gets inflamed, for example, an acute appendicitis or acute diverticulitis, the omentum rushes to that particular area and becomes densely adherent to the area of inflammation, ultimately preventing diffuse peritonitis. After knowing about the embryology of the omentum and its physiology, we start with the topic omental cysts. If we can look at the diagram, this is an omentum and these are rich lymphatics of the omentum. Once a lymphatic channel gets blocked in the omentum, a cyst can form, and these cysts are called omental cysts. Omental cysts arise due to obstruction of omental lymphatic channel. They can be unilocular or multilocular. Because they are lymphatic in origin, they are obviously lined by lymphatic endothelium. Now, what are the symptoms and signs? They most commonly affect children and young adults. Small cysts often go asymptomatic and are discovered incidentally. Larger cysts can present as palpable abdominal mass. Uncomplicated cysts usually lie in the lower mid abdomen and are freely movable. They are smooth and they are non-tender. Complications are torsion, infection, and rupture. Coming to imaging, a plain radiograph may show a well circumscribed soft tissue density in the mid abdomen. If a CT scan is done, it will show large cystic structures like this with internal septations like these. An USG may be suggestive of a complex cystic structure with septations. The treatment of omental cyst is excision of the cyst, and this excision can be done by an open method or via laparoscopy. After being done with omental cyst, we move on to omental torsion and infarction. Omental torsion and infarction is defined as an axial twisting of omentum along its long axis. So what happens is the omental twists, it leads to venous obstruction and ultimately gives rise to compromise of arterial inflow. If arterial inflow is compromised, then it leads to infarction and necrosis. Omental torsion can be classified based on the etiology into two types, primary and secondary. Primary omental torsion occurs when there is no coexisting causative condition, and the secondary omental torsion occurs when causative conditions like hernia, tumor, or adhesions are present. Omental torsion is more common in males and usually occurs in the 4th or 5th decade of life, that is between 30 to 40 years. If we look at the signs and symptoms, patient usually present with acute onset of abdominal pain, which is more commonly on the right side of the abdomen. So this is important that the omental torsion pain presents on the right side of the abdomen. Associated nausea and vomiting may be present, although it is not a must, and patient is usually afebrile. They don't have fever. However, they present with tenderness and localized guarding. If the involved omentum is big or large in amount, then a palpable mass can be present. The differential diagnosis of an omental torsion should be kept in mind, because if a patient presents clinically, then the pathologies on the right side of the abdomen has to be kept in mind, which are acute appendicitis, acute cholecystitis, and a right-handed ovarian torsion. An imaging can be done, that is with contrast in an CT scan, and in that we can observe that a whirlpool-like appearance of the omentum which has undergone torsion can be seen. So a whirlpool-like appearance of omental torsion is diagnostic of omental torsion in CT scan. A clinical condition like omental torsion justifies laparotomy or laparoscopy. In laparoscopy, as we can see in the picture, that there is a portion of the omentum which has undergone torsion, and this part is congested and is inflamed. So in laparoscopy or laparotomy, the segment of omentum appears acutely inflamed and congested. Serosanguinous fluid is often present in the peritoneal cavity. The treatment obviously is the resection of the involved omentum. What about omental neoplasms? A primary omental neoplasm is extremely rare. However, if at all they are present, they are most commonly sarcomas. If we look at the diagram over here, Then we can see this is an MRI of an omental synovial sarcoma. Can we look at the mass over here? Yes, this mass is arising from the omentum. It is an omental synovial sarcoma. The omentum is often involved by metastatic tumor deposits which arise from the intra-abdominal or pelvic malignancies. So if you look at the diagram over here, these are metastatic tumor deposits. They arise from intra-abdominal or pelvic malignancies. Coming to omental grafts and transpositions. The blood supply of the greater omentum is derived from the right and left gastroepiploic arteries, which are present along the greater curvature of the stomach. So these are the right and the left gastroepiploic arteries which are present on the greater curvature of stomach. They give out the left, middle and the right omental arteries. They also give out various vasa rectas to the stomach. So to get an omental pedicle flap, what we have to do, we have to divide either the right or the left gastroepiploic artery and divide couple of vasa rectas. So in this particular case, the left gastroepiploic artery is divided and a lot of vasa rectas are divided and an omental pedicle flap is obtained. This omental pedicle flap can be placed on a lot of wounds and which will ultimately help in vascularization of the wound and result in good healing of the wound. So omental pedicle flap has various uses as I've just discussed. One of the most common uses is usage of the omental pedicle flap as a patch for duodenal perforation repair for peptic ulcer perforation. So an omental patch is placed and it is sutured over the duodenal perforation. Omentum can also be used for anterior chest wall defects. So with that, we complete the segment of omentum. In the next video, we will discuss about mesentery and its various pathologies.